am now in control of my own life, thanks to some able assistance here. So. All right, so we're going to take just a little sidebar here and talk about stress reactivity in a general sense, and I want to talk to you some about how I talk with my clients and parents about stress reactivity. Stress reactivity, like so many things, is normally distributed. Some of us are, and some of us are at, and most of us are in between somewhere. Stress and our reaction to it is can be demonstrated by something called the Yerkes or Yerkes, I really don't know, Yerkes-Dodson curve. And this is a little bit of an oversimplification, obviously, but is instructive nonetheless. And I will sometimes break this out for my clients who are able to understand, have a good grip on kind of the academic aspects of this. So if this dimension is stress, arousal, anxiety, however you choose to think of that, this direction is performance. There's a curvilinear relationship between those two things. You need some stress in your life. Well, you guys in particular don't need more stress. You've got plenty. But if you don't have any stress, you're spending all your time on the couch. So you need some stress. And performance tends to increase as stress increases to a point, and then it falls off precipitously. So the slogan, the motto that I developed in graduate school was, "No minute like the last." And I did that because I needed to provide a little motivation for myself, and often I wasn't very motivated until I knew the paper was due the next day, and back in those days you had to go into the computer lab and use their printers and stuff, so that added an additional level of interest to the prospect. So it's not quite that simple. And it's really not quite as simple as this, but this is probably a better representation. For relatively simple tasks, people are able to tolerate a pretty high level of stress, and you kind of need some things to get going. For more complex tasks, people tend to break down a little sooner in the process. So very often, you will see kids or adults or whomever who cruise along a good part of the day, a good part of the time under relatively low demand circumstances. And in fact, they need a little nudge sometime to get going, but then as the level of demand increases, they start to break down. That's because of this curvilinear relationship. Here's the way I usually talk to my parents about it. I'm offering you this visual aid for no charge whatsoever. You can take it with you. Everybody has an amount of stress that they can tolerate. Below this level, when everything is going exactly the way you want it to go, things are good, all of your ducks are in a row, everything is fine, people are easy to get along with. Your otherwise difficult child is charming and wonderful and is learning exactly nothing about how to manage stress. Above this level, when your otherwise perfectly normal, charming child is now freaking out, throwing things across the room, is inconsolable in any possible way, when you say, "If you do that, I'm going to cut off one of your legs," and they say, "Cut them both off." They are learning exactly nothing about how to manage stress successfully. They are, at that moment, unteachable. There is no thing that you can offer them, there is no thing that you can threaten them with that is going to make a meaningful difference. The problem for many of us is that the people we work with are not like this, they're more like this. And the range of stress that they can tolerate and turn into some productive action in a Yerkes-Dodson kind of way is pretty darn small. So what we're interested in doing is expanding that range. Helping them be more teachable, helping them to be able to not fly off the handle as a result of a corrective interaction, but to be able to engage in a corrective interaction, learn from it, and move forward productively. So stress reactivity is mediated, sorry, first day with a new mouth, mediated by central nervous system, the hypothalamic pituitary adrenal axis thing, and peripheral nervous system function, autonomic nervous system. Stress does not cause disease, but it does exacerbate disease processes. So in a behavioral sense, people who are under stress don't sleep well, they don't eat well, they exercise less, they smoke more, they have poor diets, eating habits. They tend to be non-compliant with medical advice, and they are more likely to use substances, not things in general that are conducive to good health. At a hormonal level, multiple systems are affected. For our purposes, the inflammatory and immune systems are most interesting because those are things that knock you off your feet, distract you from otherwise functional behavior, and they are increasingly susceptible to infectious, autoimmune, coronary artery diseases, and possibly some cancers. Stress sucks. Too much. A little bit, good. If you want to know more about the kind of hormonal aspect of this, you're not going to find anybody better than Robert Sapolsky, who is a stress physiologist out at Stanford. He has absolutely deadpan delivery, and he's brilliant. And there's a really good show. I don't know if you've seen those like great courses things. I did the Sapolsky Great Courses stress, and it's fabulous. If this is an area of interest to you, if you are interested in stress physiology in general, I suggest that you make it an area of interest to you. Okay, now, a brief and grossly oversimplified tour of the human nervous system. The peripheral nervous system is neurons and ganglia outside of the central nervous system, right? So nerves in your toes, in your nose, in your lips, in your tongue, in your guts, and all of those things that are not your brain and spinal column, those are peripheral nervous system. That system monitors the status of the organism, you, in the environment and informs the central nervous system. It implements directions that come back from the central nervous system. So information in, you've got motor neurons and afferent neurons, and so the information goes in, brain, spinal column decides, oh, let's do this, sends the information back out, and then peripheral nervous system implements those things. So when we're talking about entering into the system at the body level in our practice, we're talking about either peripheral biofeedback, which we're going to talk about, or pharmacology. Many of us are trained to cast a little bit of a disdainful eye toward pharmacology. The person we work with in our practice was trained as an undergraduate as a psychologist, and then into nursing, and now nurse practitioner, psychiatric specialty. So a good understanding of the interrelation between those two things, and sometimes, despite what some of your professors may be, or your supervisors may be telling you, medication is the best thing to do. We are always in the business of trying to get people off of medication, and in fact, the person who works in our office usually tells patients that the day I put you on a medication is the day I start trying to get you off of that medication. That doesn't always happen, but that's always the way we think. The central nervous system is the other part, like your brain and your spinal cord. That's the headquarters, the decision-making, the processing part of what goes on. And the point of entry for dealing with the brain is neurofeedback, EEG neurofeedback, or again, psychopharmacology. So when we believe that we need to approach things at that level, we are considering pharmacology on the one hand, neurofeedback on the other hand, potentially both. There may be a sequence of those things. So I just briefly wanted to talk to you about how we think about at least those two systems. So on the one hand, the soups, the chemical stuff that goes on. On the other hand, the sparks, the electrical stuff that goes on. Everything that happens in your brain is an electrochemical reaction. And if you listen to the prevailing thinking, they would like you to believe that everything is a purely chemical reaction. It's not. Every single interaction involves the transfer of electrical energy. So on the one hand, the soups, on the other hand, the sparks. Pharmacology is a general treatment. We introduce some substance into the organism that pervades the organism and travels throughout the system, often with a focus on the brain, and we're talking about blood-brain barriers and where it metabolizes and all that kind of stuff, but it's a general treatment. Neurofeedback, by contrast, is specific training. So we don't just randomly, plug somebody's brain in, and this will make more sense in a minute. We identify where it is that we think the best information is to be found in the cortex that's going to inform that brain about what it's doing to produce a change. So general treatment versus specific. Pharmacology seeks to produce a specific result. Pharmacology looks to, on most occasions, treat a piece of the elephant, which is a perfectly reasonable and worthwhile thing to do. Whereas neurofeedback, although we're coming in from a specific place, what we're really looking to do, hoping to do, is have a more pervasive effect. We're trying to treat the whole elephant. We're trying to reduce dysregulation. And we'll talk about all kinds of potentially specific effects of neurofeedback training, but really the two things that we're trying to accomplish are to reduce reactivity and to reduce or eliminate instabilities, the two things that we talked about earlier that are the hallmarks of dysregulation. Pharmacology seeks to produce a state change, meaning that while the medicine is in your system, it's helpful. Much as my glasses are helpful to me while they're on my face, not that useful when they're in the drawer by my bedside. So pharmacology is useful while it's operating, but pharmacology doesn't affect, for the most part, any permanent change on the organism. With neurofeedback, our expectation is that in the short term will affect state change within the process, but our goal is to produce trait change. Our expectation is that if we get improved functioning in the brain, the organism improves its overall functioning, it becomes more functional in the environment, and those changes are adopted on a more or less permanent basis, or at the very least a durable basis. So if we work with somebody with migraines, we expect that whatever benefit they get from neurofeedback, they're going to keep. Absent some additional insult downstream somewhere, this is your new status, now we'll help with the rest of it. Pharmacology imposes change. Again, a perfectly reasonable thing to do, but pharmacology acts on particular pathways in particular predictable chemical ways. Neurofeedback, as we practice it, invites change. We don't put anything into anybody's brain. What we do essentially is hold up a mirror to the person and say, this is what you're doing, brain. Is this what you want to do? And then we try to provide gentle correction if the brain wanders off in a direction that we don't want, and encouragement when it moves in a direction that we do want. But we are inviting those changes to happen. The individual's brain is making its own changes. We're just providing the information that it needs to accomplish that. Pharmacology operates by a chemical route. Neurofeedback operates by an electrical route. So let's talk about neurofeedback. What we are interested in doing is promoting greater self-regulation or reducing dysregulation in the brain. We want to go from this to the best approximation we can of this as we move forward. So one of the things that I did when I was down at Monroe Meyer is directed the Attention Deficit and Related Disorders Diagnostic Clinic. And part of that, I was also sort of launching the rural mental health thing, and so I went out and did lots of talks. And among the talks I did was a talk on ADHD. And this is a slide that I included in my ADHD talk. And I included this as an example of what not to do. Because my training said that if you see a claim for an intervention that claims to affect attention deficits, hyperactivity, specific learning disabilities, conduct problems, oppositional problems, sleep problems, pain, whatever, you should run. And you should run because that's too expansive. Nothing does that. Nothing works with the entire elephant, okay? But if in fact we are, as we believe we are, affecting central structures of the brain, things like your brainstem and your hypothalamus, things that communicate with every part of the brain, if we affect changes in those systems that communicate across the full spectrum of activities, then it's reasonable to think that we may have some effect on a wide range of things, which we have heretofore categorized into neat little packages of things, saying, well, you can't affect this and this because they're not related. They are related. You may have seen recently a genetic study that said, you know, we used to not think this was true, but now it turns out that the 5 big-time psychiatric disorders all have basically the same genetic foundation, okay? As long as we're thinking about, as long as we confine our thinking, as long as we are victimized by our thinking to say we can only think about this in this way, or we can only compartmentalize this way, then we're limiting our own thinking and we're also limiting our effectiveness for our clients. Hyperactivity, I gotta tell you, is tough for us. We'll talk about that in a minute. We don't do well with hyperactivity, and there are reasons for that, which we'll discuss here in a minute. So, brain training. Brains are change detectors. Okay? What's the simplest form of learning? Everybody. Habituation. Right? Learning not to respond to something that's not consequential to you as an organism. Things that are static are things we learn to ignore. And so if we're going to have an impact, if we're going to change the way brains operate, it's going to be because we're able to provide information that is interesting and attractive to the brain, and brains are built, created to detect change. So what neurofeedback does is use real-time, dynamic, changing displays of brain activity to support self-regulation. Sorry about the long thing here. Don't you dare write this down. The brain activity, as indicated by electroencephalogram, is monitored from moment to moment, visual, auditory, or tactile feedback, which reflects that activity as provided to the client. And again, this will become more evident as we go along here. So we're going to look at brain activity, but we're not going to just take a slice of life, static picture of what's going on. We're going to give you information right now about what's going on inside your head in terms of EEG. We use dynamic multimodal feedback, which rewards productive, however we might define that, changes in EEG or brain behavior. It discourages less productive changes in EEG. It's like training wheels for your brain. You wobble a little bit, we'll give you a little correction, we'll give you a little nudge. It's, maybe you don't want to go that way. You go in a direction that we believe to be more salutary. Yep, that's good. Let's keep doing that. We rely on the brain's natural self-interest. Most of what brains do is talk to themselves about themselves. It's an overwhelming majority of what's happening inside your head right now has nothing to do with you sitting here listening to me. For some of you, that's more true than others who are thinking about what's going to happen this afternoon, but that's a difference. So what we expect then is that as the brain adopts those changes, it's more functional, the person is more successful, and brains are intensely interested in their own success, their own productivity. We are intensely selfish inside of our own heads. 30-some years ago, I had an accident. I sliced right down the middle of my right cornea with an X-Acto knife. Everybody always does that. It was not my best day. I had to have multiple procedures done on my eye. The impact caused an adhesion. I had all kinds of crazy stuff happening. Because this cut was so clean, I had to go back and have a couple of stitches taken in my eyeball. I had a patch on for 5 weeks. 5 weeks. And I had to stay mostly immobile during that time. Finally, the great day arrived. I got to take the patch off. I had a wonderful day, sat down to a nice celebratory meal, and within about 30 seconds knocked over a glass of milk. My visual cortex had no idea what to do with the new information, the new feedback that was coming in. I had gone from normal vision to no vision to the grossly distorted vision that I enjoy today. And my brain didn't know what to do. For a while, I paused at the top of a flight of stairs, and I didn't drive. And I don't know whether it was days or exactly how long, but my brain fixed it for me. I didn't do anything. I didn't do any exercises. I didn't change anything about what I was doing. I just let my brain do what brains do, which is to take feedback from the environment, notice the changes, process it, use it for the benefit of the organism, me, and adjust accordingly. So now I've got like 2 contacts in this eye, in addition to the glasses and all that. But to the extent that the software can fix my problem, it's fixed. I don't have to keep doing it. My brain's not still working on that issue. It said, okay, we're going to adjust. This is what we got right now. Let's go with that. And that's what it's doing. That's what we do with neurofeedback. That's what we seek to do. Except that we are intentional about where we gather that information and feed that information back to the individual. We are looking at areas that we believe are involved in affecting whatever is difficult for them, and say, let's have your brain do what Riley's brain does. Make an adjustment that will benefit the organism. That's making lemonade out of lemons, huh? That's pretty good. All right, a brief history of neurofeedback. In 1924, a German psychiatrist named Hans Berger was the first person to connect discs to people's cortex and demonstrate that there was this electrical signal able to measure it. In the 1960s, a guy named Dr. Kamiya at the University of Chicago did some kind of rudimentary experiments that demonstrated operant conditioning of EEG. I'm going to expand on that a little bit. Really, Barry Sterman in the 1960s at UCLA, and Barry Sterman is still like an emeritus guy at UCLA, I believe, started using and demonstrating a more robust way, I guess, operant conditioning of cats to change their EEG and to reduce seizures. If you can train a cat to do anything, I'm on board. I would have just gotten rid of the cats. So, he identified, he was actually doing sleep research. The lab was doing sleep research. And he identified a characteristic pattern on the EEG, which was one of the dependent measures used at the time, called the sensory motor rhythm. This little kind of spindly thing that happens at 12 to 15 hertz as measured right here in the center. And then he trained one group to produce more of that and one group to inhibit that. And the way that this came about was he had this kind of Skinner box sort of thing going on, and the cats were able to get like chicken broth or something like that. And then in a good behavioral sort of way, he said, well, let's train them up to wait until a tone sounds before they go over and do their bar press and get their chicken broth. All the while measuring EEG. And what they noticed was while they're waiting for the tone, they produce lots of this sensory motor rhythm thing, and it turns out to be exactly the same thing that animals produce as they're waiting to pounce on their prey. And then the tone would sound, and then they'd go get their chicken soup or whatever it was. Couldn't hurt. And then they eliminated the behavior altogether and said, well, what if we just reward production of sensory motor rhythm, just the EEG. I don't care what the cat is doing. And the cats learned to produce more of the characteristic EEG to get their chicken soup. They were operantly conditioned to change their brain waves to this calm, expectant state just to get some chicken soup. So that's what we do in our clinic now. We give people chicken soup. Dr. Sturman and his group went down to NASA where they were having some trouble with prospective astronauts who would seize when they were exposed to rocket fuel. Having a seizure while you're off in space is probably not an ideal set of circumstances, so they were interested in changing this. So they went down there and did some work with that, and as it happened, they took some of the cats who had participated in this earlier sleep study stuff, and what they found out was those cats who had participated and were subjects in this study were more seizure resistant than the other cats. And so that launched a whole series of research about potential benefits of EEG for seizure management, and it is used in that way now. NASA still uses, started to use and still uses neurofeedback as a way to train improved attention. In the 70s and 80s, there was a lot of like moonbeam interest, what I refer to as moonbeam interest. You know, it's lots of meditation stuff and lots of interest in alpha waves and stuff like that, and people got a little bit sidetracked in terms of the science here, but behind the scenes the science continued to go on. Unfortunately, this didn't help the reputation of neurofeedback very much. And then in the mid to late 80s and 90s, began to apply it more directly to attention problems, and the people whom we are most likely to agree with, Siegfried and Sue Othmer, got engaged in the field and started a place called the EEG Institute. They started working in neurofeedback because they had a son who had like 38 different psychiatric diagnoses, who had been on a pile of medications, none of which really helped. And they found out about Barry Sturman at UCLA and went there and got the kids some neurofeedback, and it helped a ton. Whereas all these other interventions have not. Unfortunately, the kid also had some kind of environmental sensitivities and got exposed to some paprika or something at his college and died. And so Brian Othmer was his name, and that has prompted a lot of their interest and dedication. These people, like, I mean, they have their lab that's in LA-ish, and like their apartment is right across the street. You know, they are absolutely fiercely dedicated, and then travel periodically to Europe, where there's a big sort of neurofeedback community. The two variables that we're working with in neurofeedback are frequency, that is, how are the brain waves manifesting? Any particular area in your brain is producing lots of frequencies at the same time, so we just kind of break them down. Beta, in the 12 to 30 hertz range, you produce a lot of beta, that's more associated with alertness. Alpha with more relaxed, calm, that's why, you know, the Orange Road people were interested in alpha waves. Theta is drowsy, delta, deep sleep. And here's kind of what those look like. Beta, alpha, theta, delta. The other variable that we're interested in is where are we going to put the electrodes to measure all that beta, delta, delta, whatever it is. And there's something called the International 1020 system. So temporal lobe, central, frontal, prefrontal, occipital, parietal. And if you go in to do a clinical EEG, they measure all of these, and you get something like this. So at FP1, prefrontal 1, and F3, between those 2 points, you get this wave. Between